welcome everyone. Welcome to IDM Scholar Society Study Club. Tonight is going to be a great night. We actually are going to start off a little bit different. So get ready, hang on. You're in for a special treat tonight. We're going to start with our sponsor from Stella Life and how that ties in even to tonight's meeting. But I'm going to turn it over to Tracy Hubble. Tracy, welcome. We're excited to have you here as our sponsor on this special edition here with Dr. Maria Miller-Rinaldi on Orthotropics. But I'm going to let you go ahead and share your screen and let's learn about a special opportunity with Stella Life.
Thank you, Laura. And get this up here, and you guys let me know when you can see it.
It's good.
All right. How are we doing there?
Perfect.
Perfect. Well, thank you, Laura, so much. It's always a pleasure working with you all. And thank you to the IDM for this opportunity to share a little more and allowing us to support you as well in all that you do. I wanted to just share a little bit with everyone about Stella Life. Some of you may be familiar with Stella Life, and I'm just going to go over a couple things because you have a great presentation ahead of you tonight, and many of you have probably worked all day today and are very tired. Stella Life is on a mission to improve lives with quicker healing, reduced pain, and continuing to reduce that need for opioids. So that is truly our passion. And our products, our wound healing products, just in a nutshell, 18 years of research went into our products. Our rinses are your alternative for chlorhexidine. So, two very important things. They are important when it comes to any type of procedures you're doing or care that the patient's taking at home for any type of healing and support post-procedure, but also for conditions such as lichen planus, dry mouth, aphthous ulcers, and your oncology patients. It's very, very rewarding to be able to help them as well. But it also is a great daily rinse too, and can be used for ongoing as well. From there, we move into our anti-inflammatory, which is our gel, our topical. So that's whenever you have any type of tissue swelling, irritation, redness, anything that's bothering you, a flare up. And that's when you would use that. It's anti-inflammatory, antimicrobial, and it has pain management in it. And thirdly, then, our products continue to work synergistically together. Our recovery kit for the last 8 consecutive years has received a top healing award from Dental Advisor. We're super proud of that and just want to continue helping people heal better. And that includes a bottle of our rinse, the gel that we just spoke of. And the third component is a sublingual spray. That is a spray, obviously sublingual, and that is going to help you to achieve a higher level of pain management. And that's again ties in with our mission statement of wanting to continue to reduce that need for opioids in dentistry. We've done a great job with the reductions in scripts written over the years, I feel. However, the epidemic globally is larger than ever, and anything that we can do to help is warranted. Our products are made in the US and patented in the US. And what I wanted to just touch on briefly before we get started with our presentations is our product Dentamedica. It's a nutritional support for those patients who are vitamin D insufficient or deficient. Statistics show that it's 60%, possibly greater in the US. So when you think about that, it's 6 out of every 10 people that walk through our doors have either an insufficiency or deficiency. And we are dealing with bone every day, so it's super important that we're considering that with their healing and supporting their dental procedures ongoing. A couple things about vitamin D. We all know that there's some risks with that, the insufficiencies and deficiencies. The biggest being that we're learning that it's more directly tied to early implant failure than we knew before, more so than ever. It also impairs the healing and the bone formation. And then we also know that supplementation does help. We also know too, though, we can't just go home and start taking 6 of our vitamin D3s and get our levels up. So there's things that we need, some cofactors to help get that, get our levels within those sufficient ranges. There's a lot of research out there that shares some of the information in regards to early implant failures and their links to the vitamin D deficiencies. An easy Google search takes you to many, many different sources, as well as we have some research on our website on our research tab for that as well. So some of the cofactors I mentioned that are important in order to get that vitamin D uptake, to get our numbers where we want them to be, is magnesium. That's the most critical cofactor for converting the vitamin D into its active form, making that more bioavailable. Vitamin K2 is very, very important. That is going to work synergistically with the vitamin D3 to ensure that the calcium's properly deposited in the place it needs. K2 does two things. It's going to work as far as helping the bones absorb more vitamin D, but it also helps that you don't get the buildup in the soft tissues like our lungs, heart, and arteries. You got your vitamin A, zinc, boron. We have the CoQ10 in there as well. And this right here just kind of talks about the vitamin D and the K2, how it helps for prevention and support. And then I wanted to go through a little bit why we're so proud of this product. Again, all of our products are made in the US. They're made in GMP facilities, which in a nutshell are facilities where we follow all of the FDA's regulations, and you know that your products are safe and effective when they come to you. They're non-GMO, they're vegan, and they're gluten-free. Sourcing is super important when you look at your vitamins, as most of you know. I know you're all very health conscious and believe in that whole body health. Our vitamin D3, most of you know, is most oftentimes sourced from lanolin, sheep's wool. We source ours from lichen, making it a vegan product. Our vitamin K2 is most often sourced from soybeans. We source ours from chickpeas, making it a soy-free product. And then even another special thing is our folic acid. There's a lot of people who don't have the capability to convert that. So we use the methylated form. We want to make sure that all of these products are very, very bioavailable and ready for absorption and work together as they should and support one another to work with building up your antioxidants and your vitamin D levels as well. So we're really proud of this product. It's not only used just for dental surgical support, it's also being used as a daily multivitamin and support with like your periodontal patients and patients who recognize like, wow, these are some great products. And as always, just share that with your doctor and they will let you know, yes, this is a great product to take, or, stay with the supplement I have you on due to these other body reasons. Whatever the case may be, we always like to make sure that medical and dental are speaking together. So super important there. And I want to I know this is just a short blurb about the products. I appreciate your time and listening about that. Stella Life offers learnings for teams. So if any of you would like to learn a little bit more about our wound care line, our oral probiotics, or vitamin D, definitely reach out via whether it be email, our website. There is a QR code on the marketing materials email that came to you. You can just click on that and it'll take you directly to my email as well. And we can set up a time that works well for you all. When you host a learning, we will send you complimentary product as well. So any questions you have, also that is my direct line. You can text me, call me, and again, email me whatever's best for you. I hope that I did not go over my time. I do have a tendency to talk fast, so I apologize if I talk too fast as well. Again, I appreciate you. Thank you, Laura, and I very much look forward to hearing you, Dr. Miller-Rinaldi and Dr. O'Rourke. I'm super excited.
Thank you, Tracy. I appreciate your sponsorship tonight. And
Thank you.
we are going to jump in here just to stay on track. I have a huge privilege, and I'm going to say with an absolute honor, to introduce Dr. Maria Miller-Rinaldi. I want to give a little background to that, is that she actually attended and is a scholar from the Dawson Academy. So she was following around Dr. DeWitt Wilkerson, yes, as my mentor as well. And one of the reasons that she actually named her practice, I said, and really wanted to start her practice about oral systemic health. But she also then went further on, attended a bunch of our courses, and she actually completed my Unlocking the Secrets of Saliva. And I do have to share because she cracks me up. She'll show me her phone. Any conference I'm at that she has me in her phone is the saliva hacker. So thank you, Dr. Maria Miller-Rinaldi. I always laugh when I see it, but yes, I say my good friends call me the saliva hacker. So you are one of my dear friends. But she graduated in 2004 from the University of Iowa, the College of Dentistry. She became a captain in the U.S. Air Force, you guys. Hang on here from 2004 to 2007. She became an ambassador for the Breathe Institute. She even is a right sleep clinician and went through the Bale-Deneen preceptorship course and got certified as a Bale-Deneen preceptor. Here's a little interesting fact. She's married also to a dentist, Dr. Joseph Rinaldi, which I think is too cute. Two dentists, and they have four boys. So I cannot complain about my five kids. She got four boys in that house. Love to know all the roughhousing that goes on because I have three, so I know. And they're 19, 17, 14, and 12. So yeah, she's also a full-time mama, and you can go follow her on a lot of her socials and watch all that because you are a dear, dear family. But her practice is Root Cause. It's integrative dental medicine in St. Louis Park, Minnesota. And she's at rootcausedental.com. But why I'm so honored is that she's really turning her passion into true oral systemic care. And she's just so passionate about orthotropics and couldn't wait to share some of her cases. I asked her, I think over a year ago, I was like, oh my gosh, you need to come on and share these cases when I'd see all her workups. So Dr. Maria Miller-Rinaldi, I know you have Dr. O'Rourke here too, so say hi on there. She's going to help us and chime in on orthotropics, but I'm going to turn it over to you about changing airways and smiles through orthotropics.
All right. Can you hear me and it's up and running? All right. Well, thank you so much, Laura, and thanks Tracy for coming on. We've been working with Stella Live for quite a few years here, and we love your products as well. So thank you for helping us out and serve our patients that way. Um, and Dr. O'Rourke was kind to join me tonight on this webinar. She is really the expert behind orthotropics and has been my mentor for the past several years and has really devoted her time and energy and her passion to try to help teach other doctors. So she is a wonderful person, and I'm just so glad that our paths cross. So thank you. And I have to thank Laura and for allowing us to do this. And Laura has been a godsend in helping our practice transform our practice as well into the oral systemic realm and helping coach us and teach us all about saliva hacking. Um, and it's really a huge honor for me because Dr. DeWitt Wilkerson was one of the mentors when I was at the Dawson Academy and did the full curriculum back in 2014 and 2015. Um, and he really inspired me, like she said, to have this integrative practice. So thank you. I know he's not here right now, but thank you, DeWitt, for making my life more meaningful and the lives of the people I get to share it with. So tonight, I want to tell you a little story about my dental career and really what led me to finding orthotropics and how influential it has become for for my children and the children that I see. Secondly, the Orthotropic Academy is looking for dentists to help join and offer this treatment to help change their lives of the patients they see. So if you find something that is resonating with you tonight, please reach out. At the end, I have all our information. Please reach out to Dr. O'Rourke or myself or the Academy. We're happy to discuss and help you guys along. All right. So Laura did a good introduction about my history and where I've been. But what I learned after doing a decade of dentistry and honing in on my skills was I was starting to ask the question of why things were happening instead of just managing dental disease. And I started noticing that the adult population, majority had a lot of the same systemic findings as well as oral health findings. And it started to really not make sense to me. And I wanted to figure out how the two were related. And so I started digging in to several rabbit holes and courses and trying to learn more about the correlation between the two. So in 2016, I read the book Gasp, which was kind of my big aha moment reading that book. And I felt like I was able to put things into a new perspective. And I started trying to learn more about airway and sleep and epigenetics. And these are some of the other books I have read that kind of helped form my new philosophy and kind of where I wanted to go. There are some studies, case studies, and research that I looked at and that I kept going back to and that kept me very fascinated with and like wondering how am I going to move forward and try to help patients. So I'm sure a lot of you have seen this study, but this, I never heard I haven't seen any of these studies when I was in dental school, and definitely not in my first 10 years. So when I saw this Harvard study about the rhesus monkeys, I was floored about the changes that can happen from mouth breathing. Um, And so that was the one of the main studies that really opened my eyes. And if this is happening to these primates, what is it also doing to us as human beings? In reading The Cause and Cure of Malocclusion, there were different case studies that the late Dr. John Mew showed. And this study was showing how a 10-year-old boy, looking at his facial form here at 10, he's a cute little boy here, nice square face, lips closed. Um, and after receiving a gerbil for his birthday, and the gerbil was living in his bedroom where he developed allergies, how he started mouth breathing and how that really changed his craniofacial development. This study was the Pirelli study, which is where 31 children had an AHI of 12 events per hour. And what they showed was that with the single treatment of maxillary expansion alone, resolved the sleep apnea to normal, being less than 1 event per hour in all the children. So to me, that was just really fascinating, and how one simple treatment really changed the course of these children's lives. And then lastly, the study by Dr. Bill Hang, who many of you should know. He's a guru in the airway world. And his colleagues did this study on 53 bioblocked children, and they looked at the pre and post dimensions of the airway and measured what the average of increase was. And it showed that there was a 31% increase in the nasopharyngeal area and an average of 23% in the oropharyngeal area, and then a 9% increase in the hypopharyngeal area. So even though it was a small cohort study, I think that was an extraordinary result of the treatment. And I personally have not seen that type of increase in growth with traditional orthodontics. So as I'm going through this and looking at these studies and the courses and reading books, I'm looking at all these signs and symptoms and trying to put this together. And what I'm seeing is that what we see in children is what we're actually seeing in adult. It's no different. They're different ages, different genders, but the behavioral signs and symptoms are the same. When we look extraorally, you see gummy smiles in both age groups, adults, children. You see people being fatigued and tired. You can see retruded maxilla and mandibular jaws, and you see open mouth breathing. So they look the same. And intraorally, I'm seeing V-shaped arches, crowding, looking, excuse me, looking at deep bites, open bites, looking at tongue posture, looking at tongue posture and tongue thrusting. All of it develops the same way. Here you can see narrow palates, tooth grinding, worn down dentition, tooth erosion, enlarged tonsils, inflamed gums from mouth breathing, and probably periodontal disease as well. So everything is looking similar in children and adults. And what I wanted to do was figure out how I can prevent the children to becoming those adults that I'm seeing today. Because though I want to help the adults, it is very challenging when you've gone through decades of having of having
breathing
thank you.
issues.
Thank you, of having breathing issues. Um, and all of how that translates to systemic health later on, where you see these chronic inflammatory conditions developing. So that's where I decided, one, I wanted to help my children, but also look at treating others. And that 3 to 12-year-old is the prime time because those jaws are growing and they're very malleable. And this is the slide I'm sure you've seen from Dr. Audrey Yoon, who shows that the maxilla and the mandible have their most exponential growth in about the first 5 years of life, and the jaws are about 70 to 80% fully grown. And then we have the small window of opportunity from about 5 to puberty, where we still have growth, but it's slowed down. So that's why it's really important that dentists are recognizing and looking at those signs and symptoms that I just showed on the previous slide to try to intervene and change a child's health trajectory. So 2018 and 19 was a big year, a pivotal year in my life, my dental career. So a couple things happened. One, I got to read Dr. Wilkerson's book, The Shift, which really formed my new philosophy and how I knew I wanted to practice when I had my own practice. So that that was pivotal. And then two, Dr. Ben Pospisil, who's actually the president of the Orthotropic Academy, he is one of my dear friends from dental school. We were classmates. He was in my wedding, and he and I went to a Dawson alumni retreat, alumni meeting, and Dr. O'Rourke was speaking at it. And Ben and Dr. O'Rourke had been working together. And when I heard her speak about orthotropics and sleep disordered breathing, that was the moment that I really knew I felt like this piece had been missing, and I wanted to learn how to do the treatment, and I wanted to first offer it to offer to make my children do the treatment and try it out and see if I really believed in it and what the outcomes were. So then I could decide if I wanted to practice it clinically with other patients. So I think as many dentists that go through this training, their first reason why is really their children. They are seeing what's happening to their own patients and seeing maybe the orthodontic relapses that occur and issues that come about from having traditional orthodontics, and they want to try something different and better maybe for their children. So this was my family, and I was hitting this right when I would have thought kids should be getting orthodontic treatment, around 12 when they're losing their baby teeth and getting their permanent teeth in. So I learned this just in time, really. So my son Joseph, who was 12 at the time, and Rasmus 10, they were my first subjects. And then my other two kids followed. So, what is orthotropics? So, it was invented by the late Dr. John Mew, and it's the premise based on guiding facial growth forward while encouraging proper oral posture. So, to us, what proper oral posture is: tongue to the palate, teeth are lightly touching, lips are together, they're nasal breathing with no muscle compensation. So I wanted to give you a preview of the appliances because that was always a question I had when I was learning. I was like wondering what they were in my head and how would you do this. So I'm going to just give you a little synopsis, but if you want to learn more, you'll have to come see us in the course. But the first two on the left, so that's a stage 1 upper BioBlock. The second photo is a stage 1 lower BioBlock. And so you will see that they're class to baby teeth, the baby molars, and they each have an expansion screw, and the top one goes to about 10 millimeters and the lower 7 millimeters. And so you are expanding transversely in that first phase of treatment, but what you're doing as well is using the catenary wires, which are right here behind the front teeth. And what those are doing are helping to reposition those front teeth by intruding and protruding, which is helping to reduce the indicator line. The indicator line is a measurement, it's a screening tool we use to see if the maxilla and the mandible are growing down and back, or are they growing down and forward like they're supposed to. So it gives us some information about how far we would like to go forward based on their gender and their age. So we're trying to normalize those kids and set them up to have that forward growth. And then in the second phase, which are the last three appliances, you're using an eating appliance, we call it, the helper appliance. So you can see the screw is eliminated at this point. Oops, sorry. You can see the screw is eliminated at this point, and that allows the tongue to have the ability to be more in the roof of the mouth, which we want to promote. But then as you're training, you get into the stage 3 and or 4. So I'm just going to talk about one of them because we use them for different reasons, but for the same goal in the end. So it's only clasped to the upper arch. It's not a joint, it's not connected to the lower arch in any way. And what it's doing is we have now provided a new bite scenario where we have a large overjet and we're allowing room for the lower jaw to grow forward and translate forward to meet the front teeth. So it's a little hard concept to kind of visualize sometimes until you actually see it done on a patient and what happens. But we're going to show you some pictures. We're going to go through some cases and faces here so you can understand where we go from point A to point B. The other thing I wanted to add, you're probably wondering, like, why are there all these little extra wires? We call these approximating wires. And what we're doing basically as you shed the baby teeth and await for when the permanent teeth are coming in, you're using these wires to help guide the teeth forward. Because we've expanded so much more than I would say most orthodontists do. We have a lot of space. We also want to shuffle everything forward, create room for the other molars that are coming in.
Before Maria goes on, those little extensions that you see are for behavior modification. We're training the child to keep their mouth closed together. And so if they open their mouth, it gives them a little bump. So really the crux of the treatment is changing the posture of the child. So that, because in our belief, that's the poor posture has led to the symptom of the crowded teeth.
Correct. Thank you, Karen, for adding that. So what we always like to say and what Karen has taught me is that with these appliances, though rigid, yes, we are providing the instruments to create the environment and change the structural component of the jaws. And then the child is first consciously learning a new posture. And then that consciousness becomes unconscious behavior where they can then retain that long term once the appliances aren't in. So the crux, like she said, the crux of the treatment does come down to maintaining oral posture. And along with that, we're usually encouraging myofunctional therapy. Almost on all the patients I see, we're trying to incorporate myofunctional therapy. So we're going to start with this first case, who happens to be my second born son, Rasmus. And this was the case where, like I said, I had two sons that were doing the treatment at the same time, but two had very different situations and behavioral situations. So just to give you a little bit, this is going to probably be my longest story out of the case studies, but I feel this is important because this was so impactful for my son and why I decided I wanted to bring this treatment to the clinic. So Rasmus had been struggling for a couple years from like 7 to 9 years old with anxiety and depression. He even had talk of dying, things that, a 7 through 9-year-old you wouldn't think should be talking about that. But if you look at his other signs and symptoms, he was a chronic mouth breather. He had worn down teeth. He had a super gummy smile. He had a deep overbite, crowding. His jaw, was retruded. If you look at the profile picture, he had sclera showing, looking under the eye. So his soft tissue dysfunction was following, his hard tissue. So he reacted very negatively to things. He even had like temper tantrums where he would hit his head on the floor. So it was a really hard couple of years for my husband and me, taking him to different specialists to try to figure this out, like what is going on. And nobody really had an answer. Everything we did came out he was normal. And they basically said he had anxiety. And I was like, yeah, I know. I said he had anxiety. You didn't need to tell me that, but there was nothing that was found. So we're carrying on. And I decide, I'm going to do this orthotropic treatment. So the thing is right after I saw Dr. O'Rourke at the Dawson alumni meeting, that following Monday, Erasmus was lined up to have an early phase of expansion done and braces on the upper. So I was trying to figure out, I was in a conundrum of what to do. And my friend Dr. Ben was like, just go through with it. We really have to figure out the logistics of how we're going to do this training and do the treatment because Ben lived 5 hours away. So I went through it. And then after 4 months, we were done. I then took him to Dr. Ben and he started helping to train me how to treat him with orthotropics. So here's the initial pre-ortho photos. And then this is obviously he's getting done with treatment. And then you jump to where it says stage 3 underneath. So we went through the phase 1 expansion, but I went to the phase 3 here to show you because it really shows one, how we reduce that indicator and reduce that gummy smile. And then two, if you see how he's in this stage 4 appliance, you see how he's really forced forward. That's his new bite position. And that appliance is reminding him to stay there. So they become more relaxed as they wear this appliance, all right? The thing is, in the stage 4 appliance, after a couple months of him acclimating to it, Rasmus came up one morning and I always ask the kids, how did you sleep last night? And Rasmus was like, I slept great. Mom, I've never slept like that before. And that moment was the moment where I started to put the pieces together a little bit more and how much really sleep and the breathing is affecting my child and others. So I suspected, I mean, he'd been a mouth breather for like a decade, that he has not been oxygenating properly and therefore also not sleeping properly. And he wasn't meaning to act like this. And his sympathetic nervous system was out of whack. And so after about 3 to 6 months, we just saw Rasmus's anxiety, depression, everything just slowly went away after he was nasal breathing. And so that was so powerful. And it was really emotional for me too to watch that happen. And as a mother, you don't know what was going on. And to know something this simple and basic in science, how we're supposed to be breathing and why we sleep a third of our life, how important that is. It was just really powerful. And then that was the case where I was like, I got to spread this to other parents because I know other parents are struggling. So here's Rasmus. I think this says a year post-op at the bottom here. So, with my first 2 cases, I will have to say I was a little bit of a cowboy learning this treatment because it was also during COVID. And I wasn't practicing in a practice, and I was going down to Dr. Ben's office and talking to Karen, and I was doing this on my kitchen counter. But considering all that, and as you're learning, as you're going, you make mistakes. So I think being one of my first 2 cases, I think the outcome was pretty good, and the pictures don't tell the emotional component side of it.
What was surprising to me was how the gummy smile got worse just with that expansion at the orthodontist. We support the front teeth and we don't pull them back, whereas those rubber bands are pulling things back and down. And things got worse for him in terms of that gummy smile just in that short time of the expansion. So
And the lower jaw. So here's a pre-Cephin panel that I obtained from the orthodontist, and they weren't doing CBCTs then, and some still aren't. And I didn't have the ability to take one, but I wanted to show the CBCT that I took last year on Rasmus. Oh, I'm sorry. Because have taken hundreds of CBCTs on adults, and I have quite a few on children now. And I will tell you, and hopefully some of you can agree to this, I use beam raters, and I always get this little grading system with the, the red to white outline and looking at the volume area, the area of the airway. And normally what I see in appearance is an hourglass appearance or a funnel in the airway. And this one I would classify more of like a road or a highway, you know. There is, yes, a decrease from the 19 to the 10, but it's not as dramatic as the ones I see typically every day. And when you look at the color coding system, you know, he's in blue, white, and green. And I rarely ever see that on an adult. Definitely none of the kids that I'm treating in orthotropics. So I don't have a comparison of apples to apples. But I don't think my kids were any different in presentation than any of the other kids I'm seeing, and seeing that their airways are, 3 to 8 millimeters at most. So we're going to go through some cases and faces, Dr. O'Rourke and myself, and we're going to do different age groups. So there's the 3 to 6, which we call the early interception age, and then the 7 to 12 age is we call that full orthotropic treatment. So early age is the treatment's usually 6 months of active expansion, and then we hold for 6 months without expanding, and then we slowly let go of those just to nighttime wear. And then the older kids, depending on what age you get them, it's typically like a 4-year treatment plan. So it's really long, it is challenging, but the benefits and the outcomes are fantastic. So I wanted to start with just this early child. This was a 4-year-old. Actually, this was a colleague, a dentist who brought her child to me for airway concerns. And so just looking at this, you see the deep bite. You see that the upper canine, especially on the left, is almost down to the gum line. And then obviously there's no spaces between the teeth, the baby teeth really. And he's got a lip tie there, you can see. And so I wanted to show this because the top row is before and the bottom row is after 6 months of treatment. And you can see how much expansion we got. And that was about 10 millimeters of the screw. And coincidentally, you want to be able to fit like a nickel between each tooth or about 10 millimeters of extra space when you have your primary teeth in to accommodate for the size of the permanent teeth. So if you just look at the teeth, like to me, you're like, wow, looks great. But what I've learned with the treatment through Dr. O'Rourke is that, the treatment is really secondarily about the teeth and what the teeth look like. It's really about the facial form and profiles and creating those broad smiles. So you got to learn to not get too hung up exactly on having straight teeth, Hollywood smiles, because we know now what that has led to. So the cases going forward, you're going to see less of the teeth, but more looking at the faces and the profiles. So here's a little boy. This was a 4-year-old boy whose mother found me. She actually had written to Dr. Mew and asked for advice and somehow ended up finding me in Minnesota. She lives a couple hours away. So, he had narrow intermolar width of 28 millimeters. You can see that there's minimal primate spaces available. You can see the mentalis straining here. And he just looks mad. He's actually a very sweet little boy. He looks mad, but he's a sweet boy, and he was fun to treat. But you can look after we just went through expansion phase. You can look at the amount of spacing we got on the upper and lower arch here, but look at the change in the face. Like to me, he looks like a different child. And yes, he has a tan in the post-op pictures and a much better haircut, but look at his profile of his forehead and his mandible and how once we unlocked the bite, how his jaw was able to translate forward just on its own. So, and now this child now is actually in myofunctional therapy with my co-provider at work and trying to help maintain this. And we'll just have to see how, when his permanent teeth erupt, kind of how this plays out. Maybe he gets everything right, the posture right, and Mother Nature will take care of itself. If he doesn't correct that, then he may be a candidate for another round. Karen, is there anything you'd like to add on little Cal?
No, but I think that you have to appreciate why he looks like he does in that first picture. And it has to be that he's not breathing well, he's not feeling well. And what transpires when you open up that airway, and it just makes him a different child. And we've seen it again and again, but you don't necessarily see it if you're not taking the pictures because it's a subtle transition. But yeah, I think Marie is showing great work here and how important it is to intercept as soon as you find out that there's a problem.
Karen, this is your case, so you can take this one.
So Maria chose the cases in the slideshow. And this little guy had an anterior crossbite. The front 4 teeth were locked. He was a twin, and his twin also had the same play. And so we treated him at 3.5. And because I'm a general dentist, I'm able to follow them in my practice. You know, this is him 2 years at follow-up. But my philosophy is, as soon as you recognize that there's a problem, try to normalize it. And it's always bothered me in orthodontics that we wait and things get worse. And it just doesn't make sense to me. The orthodontists still say, wait until the 6-year molars are in to correct a crossbite. But why? This kid is now on a path of normalization. So as soon as behaviorally you can treat, I'd get in and treat.
Here's another case that I treated early on, and little Ruth here. The top, you can see the top photo. I think that she looked pretty sickly. To me, she was very pale, maybe deoxygenated. You can just see the dark circles under her eyes, the mentalis straining, the full buccinators. And then from the profile, I didn't initially even catch this, and Karen pointed it out to me, was like, look at her eyeballs. They're like further out almost than her cheek or at the level of her cheek. So her maxilla is pretty deficient. She's almost sunken in a little bit, and then her lower jaw is retruded as well. So, and I couldn't even get the retractors in her to take a picture because she was kind of, throwing a fit and wouldn't have it. So I had to take that upper picture the best that I could. And also going through this process, I didn't ever realize I would be presenting on a webinar like this. So there's some pictures that aren't as good as I would like to show, but it also shows some errors in how you could get better at things. So if you're doing these cases, document, document, document. You never know when you're going to be asked to show them to somebody. But so you can see she's at 28 millimeters intraorally, no primate spaces. And then what I did with her is we did it what we call an early advanced treatment. So we did the expansion, and I used reverse pull headgear to pull that maxilla forward in order to create overjet and to allow the lower jaw to grow and translate forward already at age 4 and 5. So I hope you can appreciate the facial form changes. And the profile there, like you can see her lower jaw is definitely more forward, but she's still pretty deficient even with this improvement. She's really probably a candidate for a second full round. Unfortunately, my little Ruth moved out to the west, and so we weren't able to do that other round. But what I do feel good about is that we got her to a much better spot, and allowing room for her. Her permanent teeth now are coming in, and they're coming in nicely. She has done a ton of myo work, craniosacral work. Her mother's super into all this stuff. So she has an awesome parent who's really being her advocate to help her grow and develop properly. And so we're just trying to work to help find her an airway dentist out there to continue her case. Karen, do you have anything to add with Lo Ruth?
Just when you're looking at the profile, our targets for a developed maxilla is for the cheek line to parallel the nose line. And for her, the cheek line drops straight down. So it just tells you how deficient her maxilla is. And if the maxilla is that deficient, it's held the mandible back as well. And you can imagine her airway. So she is you can tell by looking at her, she's a sick kid, or was until she got some treatment.
All right, Karen, this is your case.
This again was a little girl with what I call a crashing occlusion, where the
I don't know why I was doing that. I'm sorry.
Where she had F through J in crossbite locked in. She was a bedwetter, and this was problematic for her parents, as well as having some other medical symptoms. So we expanded her, and she stopped bedwetting within 2 months. There was a study done about bedwetting and expansion, and it was a small study of 10 cases, but every case resolved the bedwetting with expansion. So there's definitely an airway, a component, airway component that's linked to that crossbite and to that expansion.
This is a child, again, of actually a dentist friend who, sorry, that keeps doing that, of a dentist friend who brought her child to me. She was concerned after hearing me talk in the office about gummy smiles and narrow palates and down and back growth. So so this was an early advanced treatment too, and we did do reverse pull headgear on this child. And these pictures are actually just kind of showing after the first 6 months. I just wanted to show you the change in just 6 months of just the expansion that occurred. So you can see how his smile is nice and broad there, and the gummy smile was reduced. And again, his skin tone just looks even a little bit better. Of course, that could be a little bit of the black backdrop and the white backdrop. But to me, even under the eyes, he just looks a little healthier in general.
You can see consistently these kids are pale in their first photographs. And, I have a slide in particular that I show where after the expansion, we took the photo in December. He hadn't had sun, but his color looked better, and they're just better oxygenated.
All right. So we're going to now show you some cases that are really, I think, fascinating. And I wanted to start with the OG of orthotropics, Dr. John Mew. So show a couple cases here. And what this really, why I really like this template of photos is because he shows the 11-year age before, the 16 after, and then a 31-year-old photo of showing the stability and how the bite has remained. And I think that patient has a beautiful profile there, and you're matching up the parallel. If you're looking at the parallelism between the nose and tangent to the cheekbone, that looks pretty spot on. And where her lower jaw is matching up with her maxilla, I think that is a good representation of, if you acquire the correct posture, how this can maintain. And really, our retainers should be our tongue and our muscles doing the work to keep our teeth in the right position too. So this was actually one of my first clinical patients. The parents trusted me to do this case. You know, it's kind of scary. I was very honest with parents when I started doing this, saying, hey, I've only done this on my children, showing them pictures you know, she trusted me enough to let me treat this to her child. But I wanted to show this. We don't really use the Bolton norm as much, but I like to pull that out and just see like how close can I get to that Bolton norm by doing this treatment. And this patient, you know, this was just taken actually a few weeks ago, and she didn't present. Her parents were not complaining about any sleep or breathing issues. I happened to take her indicator line and was looking at a little bit of her crowding and her posture and offered the treatment based on measurements of narrowness and looking at her tongue, and it was larger than her upper arch, knowing that she was probably going to have oral dysfunction if she can't place her tongue in her palate. So I offered explaining that we could help by doing the expansion and the forward growth to get more anterior growth and to try to reduce the risk of sleep disordered breathing in the future. So the parents decided to move forward. And I kind of put a little series together. So this was her pre-op photo. And you can see now we have the baby teeth have exfoliated and we're getting the permanent teeth. Premolars are erupting. And what I wanted to show is that this is kind of hard to believe until you actually see it. But when we're using the appliances and we're shuffling these teeth forward, because you have all this space from the expansion now, we shuffle the premolars forward and that's it. And then you relieve the clasps on the appliance and you watch the first molars drift forward. So I didn't put any pressure on these molars. I didn't use anything. They drifted forward as the second molars were coming in, and you can see that the second molars are now in. So as you create space, the body knows what to do. It may not be perfectly straight, but they know where to go in the end. And we're going to show you a couple other cases of that happening. Dr. O'Rourke, the next.
Okay. I'm not sure why Maria chose this case. Do you have any particular reason, Maria? Or...
This case? This was the gummy smile, whoops. Was it the myomunchie?
What's significant to me is that this child was still sick when she came. She snored, she had restless sleep, she sweated during the night, and she sleepwalked. She had seasonal allergies. She had her tonsils out when she was 5, but that wasn't enough and almost never is enough because that downward growth happens before those tonsils are removed because the posture has been bad and they've had their mouth open and their mouth hanging open. So having the tonsils out is a part of the treatment, but it often is not enough. This takes a village. So she didn't have too bad of an occlusion, but she really had a narrow palate, a gummy smile. And she was very long from her nose to her chin. She was straining to keep her lips together. You can see in that profile shot. So we were treating really to get that jaw forward and get her healthier, not so much the teeth.
And the jaw changed so much in just a couple months after the stage 4 delivery, looking at how that was able to translate forward.
What we can do with this treatment is really non-surgically close down the bite by getting the permanent teeth in the position they should be in, and then removing some baby teeth so that the lower jaw can close down. So she won't have as long a face, won't strain to get her teeth together. So starting early in the primary dentition gives us a lot of options that are not available later. The only way to do this once she has permanent teeth would be to surgically do the correction.
Oh, and this is her.
Yeah, this is her before and after. So her occlusion really wasn't too bad, but for me, the face had showed her real problems. That's all. You can go ahead. By close down, I mean you can bring the mandible, rotate the mandible up so that your nose to chin distance is not as long.
All right, this is a case that Dr. Ben did, and I have to move the little bar here so I can see how much time. So it was about 4 years of treatment, full orthotropics, and you can see that the boy presented with an severe underbite. You can see kind of the sunken in under the eyes and the flat maxilla and the mentalis straining. He has like a Cupid's bow almost with the downward frown there. And Dr. Ben was able to, through the full series of treatment, able to correct that. Anything else, Karen?
Mm-mm.
Okay. This is a case that I'm actually in the progress of treatment right now. We're coming to the end, but this child was actually a friend of my son, and the mother came to me asking me what I thought of the orthodontist treatment plan, and it was to extract premolars. And so I told her I didn't like that idea and let me ponder to see if this is a case that I could consider for orthotropics because he was older and he was in the permanent dentition, which it can be very challenging if you're at that stage because you don't have the ability to reduce the indicator and move that maxilla forward as much without creating a posterior open bite. And it's much
Anterior
harder
open
to
bite.
move. I'm sorry, what?
Sorry, an anterior open bite.
I'm sorry, an anterior open bite. And you don't, it's much more difficult to shift the permanent premolars and molars in the back once they have fully erupted. But I had a hard time sleeping and telling the mother that I couldn't help her. And so I tossed and turned about whether to help this child or not. And luckily with Dr. O'Rourke's guidance through this, we were able, I think, to have a successful outcome. So if you look at that, the pre-op, look at that severe gummy smile, down and back. He was a total mouth breather. Even though he has his lips together here in this picture, he's a chronic mouth breather. And I actually did a sleep study on him, and a sleep physician did diagnose sleep apnea, moderate sleep apnea at 12. So this is where we're at now in the process. We're at the end. We're waiting for the first molar and second molar to shift naturally forward a little more. And so probably this summer, once he's not wearing the appliance all day, we're looking at doing a sleep study, and I'll get a final CBCT, and we'll see where his sleep disordered breathing lies and if other treatment is needed for him. But he's also been in myofunctional therapy for about a year, which was a major help for him in learning to keep his lips closed. So I think his outcome is pretty good, even though this was a pretty challenging case for me. Karen, would you?
This little girl was started around the age of 5, and I used a myomunchie originally. She went through 2 munchies to correct her anterior crossbite. What this shows as you go on, yes, the munchie corrected her crossbite, but look at how her face came alive when you developed the maxilla forward and brought that jaw forward. She went from good to great. And a lot of people are using the MyoBrace and Healthy Start, and they are great tools to train myofunctionally. But if you think about when we give injections, the maxilla, the bone is softer. We can infiltrate. On the mandible, we have to give a block. When you put an appliance in that connects the upper and the lower jaw, it's the upper jaw that comes back and rotates down. So those appliances, while they may look like they're correcting the teeth, if you look at the face, they're taking the jaw back and are probably doing certainly no good for the airway. So I just caution people in using those, especially in older kids. I think they're great in 3 to 5-year-olds to train the myofunctional behaviors, and they have been shown to help kids sleep better because they're training them to keep their mouth closed. But I would use them with caution.
Here's a case that Dr. Ben did. You can see the severe, I apologize. I did not know I had that set on those interruptions there. But you can see the severe palatal crowding and intermolar width. This patient also had blocked out both cuspids and one bicuspid. One bicuspid was blocked out. You can see when you look at the profile how he is down and back of both arches. He doesn't really have a defined mandibular plane. His cheekbones are pretty flat. So Ben took him through the full series of appliances and was able to naturally get those teeth to come in without any surgical intervention. Karen?
And this case is just showing, again, the long-term stability that we see in these cases. You can see the myofunctional dysfunction in her chin, how she has tension, how she has, I don't know if you can see her tongue kind of thrusting through where that number 7 would be, but resolving the myofunctional issues, getting them nice expansion. You just see the smiles, the teeth filling the smiles, and you see long-term stability. So I think there's not much more to say to this because I'm seeing a lot of questions come up. So we'll try to move through towards the end.
All right, we have 2 last cases here to show. This was a case Dr. Ben did, and I just wanted to show you the Panorex prior to treatment. She has those impacted canines, and she also had her lateral incisors were rotated. She was seeing an orthodontist, and they recommended that they extract premolars to get the canines in. So the mother sought a second opinion with Ben because she had heard about orthotropics. So like I said before, it's a little challenging when you're dealing with permanent dentition to get the jaws to go as far out as you would like. So there's a little bit of compromise. However, he was able to do this without extractions by creating space, and Mother Nature took care of it, and those canines dropped in. I think that's pretty amazing. Here's a pre and post Panorex. Ben ended up leaving the brackets on because she was bracketed and took them off the molars to be able to clasp with the devices. And then lastly, I'm going to end with my oldest son, Joey, who I said was my first victim here. Joey did not have signs or symptoms of sleep disordered breathing, but he did have signs of, improper growth. He had a mild gummy smile. He had 100% overbite. He had some wear and erosion. Um, but he never complained of sleep and he didn't really have behavioral issues. But that didn't mean that didn't mean we shouldn't treat him because we're seeing where this can head as well. And I'm trying to set him up for long-term success. So again, I will say mistakes were made and I had to, learn how to move wires and correct things. I would have liked him to have a not as deep bite as he ended up with. I will tell you, Joey was 12 when we started treatment, which is a hard time to start. And the reason we went for it is because he was dental age, he was really delayed. He did not lose his baby molars till he was like 14, and he got his second molar in at 18. So we were able to take advantage of that and do the treatment for that reason. And by 15, Joey was so over the treatment at that point, being in high school. There was some spaces left between his teeth, and he just wanted to be done. So I also had to learn in that, I was trying to go for, perfection and straight teeth and teeth all touching. And again, like taking a step back saying, hey, we've accomplished what we have needed to accomplish at this point. And my biggest achievement, I feel like in his case was this. So again, I don't have apples to apples to compare because I didn't have a pre-CBCT, but I will tell you again, I have not seen one B reader report where any adult has that grading of an airway in above 400 millimeter square for the area. So I consider that a win. So one thing I'm going to do this summer with Joey is I talked to him the other day about actually just doing a watch pat sleep study, and I want to see what it says, because obviously this is just him standing up at his best, during the day, but I do want to see functionally what he's doing. So, and going forward, hopefully I'm going to hopefully publish a couple cases in the AGO magazine they do, and I want to keep track, like Dr. Hang has done, and try to provide more evidence of this treatment. And I think that will be more valuable for dentists wanting to learn this treatment. So hopefully those cases were impressed you and maybe have you thinking twice about the treatment. And hopefully we are provided some interest in it. And you have the power to change these children's lives by changing the profiles, their smiles, and just their overall health. And if we don't do it, then who's going to do it for our future generations? And then I wanted to add a thank you slide to my support group. So my family, that's the Rinaldi six, my husband, who's had to endure this time of training and implementing, and my four sons. And then Ben and Karen being mentors on this journey, as well as my entire team at Root Cause. They are very passionate, hardworking individuals who really support this oral systemic health and have really promoted and helped support my journey through orthotropics. So thank you to the people that I'm surrounded by. And if you want more information, there is a course that we are offering in 2027 and how to provide orthotropics, how to implement it into your practice, going through the treatment. And it also comes, with consultations to help you work through treatment with children. It's 4 weekends. And if you have any questions, you can go to the website. There is a contact us bar where you can reach out to Riley. And if you want to, for some reason, get in contact with me, my website is there, my email, and our office number. I am happy to set up a call and talk about it with you. And I know Dr. O'Rourke is too. So we're trying to trying to keep this orthotropic thing alive and just spread the word and provide another treatment option for our children. So thank you.
Thank you so much. I want to open up. You do have questions in the chat. I'm actually going to start with one that was sent in previously. I'm going to drop that in there and then read it to you guys. I think that it's just really important to kind of explain. I think some people, I know Dr. O'Rourke, you're trying to answer one of those top questions in there. So I'm going to give you guys a minute to go look at that. But the first one that was sent in says, might you agree that deciduous skeletal dental class 2 malocclusion, so a distal step second molars, class 2 canines, excessive overjet, and retrognathic mandible in this 3 to 5-year-old child, toddler, will sometime, if ever, spontaneously self-correct? Will they grow out of it? I think that's the biggest question that people want to know. And I think we all kind of think that, well, would they have grown that way? Would it have corrected that way? So what is your take on that? Because you're showing so many amazing changes, and just while you're thinking through that, I just want to thank you for sharing your family. It makes me emotional because, you know, when I talk about my children, and just thank you to your children, really, for allowing you to do that as well. I know how my boys are when we talk about them. They're not as much the girls over there, you know, yeah, show my photo. And so I just so appreciative, and I got emotional there just hearing, really about your second son. Just, I think we don't talk about it enough, right? The mental health, you know, we think, oh, it's a phase or this or that. And just being highly on the medical side, how easily a child can get pushed through what I call the sick care system. And for you to just kind of stop as mama bear and say, hey, right, I'm going to do everything I can. And I think a lot of us being in the dental field, what can we do? These are all our children. Like you said, it takes a village, it takes a community. So thank you from the bottom of my heart. Really, it was touching. So with this question, are they going to self-correct? What's going on here with all of this?
I think we can both answer, but I think we're probably both in agreement that the question is how did they get there in the first place? So addressing that cause first. And you can't, I got this from Dr. Hang, but you can't expand yourself out of an anterior posterior problem. Probably some of you have heard that. And we can use our instruments, like I said, to help provide the tools to set them up structurally. But in the end, you have to address the root cause, and that's the posture component of it. So in my experience, though limited to compared to Dr. O'Rourke's, is that time it's not going to improve. It's probably actually going to get worse. Dr. O'Rourke, would you have another answer component to add?
I would agree that it's not going to self-correct. We certainly have to look at what caused it, but once it happens and you have that maxilla forward of the mandible, the posterior teeth settle into that relationship. And unless we unlock all of that and allow the mandible to come forward, it's not going to self-correct. So it's a functional problem that ends up being a dental problem. And so we kind of unwind the dental in order to correct the functional. Maria, can you maybe take down your slides? And
Oh, I'm sorry.
you might
Sure.
be able to be visible.
And I know,
Oh,
Dr. Rourke, you were kind of addressing in the chat, they were asking about this closed down statement that you made. Maybe take these in two questions. One,
I
just
don't know if I can become visible on the screen, but I did misspeak somewhat when I used the term closed down. So what we believe happens is the tongue is the only muscle in the body that has an origin and not an insertion. Or has, yeah. So here's the maxilla and the tongue belongs up here. If the tongue drops down because they're breathing with their mouth open or habit or thumb, then the maxilla collapses. It comes down and back. So Orthodontically, you're corrected here where it's down and back. Orthotropics is the only treatment that takes that maxilla up and forward and then brings the mandible to meet it. But we also are trying to correct that posture and get that tongue to stay up in the palate in order to keep that treatment stable. So when I was talking about closing down, what I was really talking about is we take those teeth up and forward, and then the front teeth are out of the way, but you have a couple baby teeth here still holding that bite open. We can wiggle those out early and rotate the mandible up. And I was saying close down, but we're really rotating that mandible up and forward and creating a less length to the face so it's more comfortable to get the teeth and the lips together. So I hope that explains it.
Yeah, because they're worried about going down and back.
Down, where we're really rotating the mandible up.
Right, going up. And then Dr. Kev, I just want to give a shout out early on. He was just addressing really what you're talking about, Dr. Miller-Rinaldi, is just, treating as soon as you can behaviorally. And so there's a long paragraph there, but just really on any of this behavioral guidance, like what you guys are looking at, we're talking about behavioral issues in children. And, all of us talk about this in this airway world because I say we talk about it with adults. I mean, we have angry, mad adults out there as well, with anxiety, depression, ADHD. It's not going away. It's manifesting itself, I say, as an adult issue. But could you just touch on that briefly? Because that was part of the story. But obviously, I think all of us, and that's why I gave a thumbs up because Dr. Wilkerson isn't here, but is a huge component. We always say if we could start early with our children, would we not have these issues in our adults? And I say that on every aspect, of health. Say that a gateway to health. We're talking about GI issues. We haven't even opened that door, but then any systemic issues, vascularly that we're dealing with as adults, and that goes into brain health and metabolic health. So touch on that just briefly, where what you're really seeing and changing.
Okay. Well, a child by the age of 5 has 70% of their head and neck development. And by the age of 12, they really are at 100%. And it's a huge trajectory from from 0 to 5. And that's when we've got to get in there and treat. And then we're going to resolve these problems. Whereas by the time you treat an adult, you're managing them. But we have so much potential by treating these kids young to really correct it that it's just invaluable. But I'm not sure if part of the question was, what about these behavior issues? Yes, the kids that you're treating have behavior issues, and it makes the treatment more difficult, but it also makes it worthwhile. We just have to brave through it and help them through it, and they get to a better place.
Yeah,
Yeah, and I also, no, that's okay. I was just gonna say, like, we are, if we're asking children to behave all day and be in school all day and behave, and these kids are lacking sleep. And now we've been in the era, of technology, which is another contributing factor that is affecting their sleep quality as well, which is just making it more, I would say more severe and difficult to treat, both components. But if kids aren't sleeping just like adults, you know how you are when you don't get a good night of sleep, and um sorry, lost my train of thought there, but I was gonna say, if you are not getting sleep and you're in sympathetic overdrive every night and not being oxygenated, how is that not affecting, their capabilities to function the next day? And that's happening night after night. Um, so that's why Rasmus's story was so powerful to me, just knowing that the nasal breathing, proving that how effective the nasal breathing was and keeping his lips closed and then getting more probably into that deep and REM sleep that really changed who he was during that period of time. So I think going back to basics, honestly, if we could help our society learning what we put in our body, what food we're putting in our body, and sleep, getting quality sleep, and breathing like humans were supposed to do with our nose and use our mouth as our emergency line, we would have a different set of human beings walking around.
So somebody asked about compliance, like how do you get these children to comply, which I think a lot of people would ask. You're talking 3-year-olds you're treating.
You
That's
know,
You
the
know,
first
I mentioned that 3.5-year-old was a twin, and I took the impressions on this one that I pictured first, and then his brother, I tried to take the wax bite first and couldn't, he was gagging. I had a really hard time getting the bite. So I said to my assistant, put blue mousse in the tray. You have to get creative. Got blue mousse because it sets up quickly. And we got our impression. We're talking, this was probably 2015. I'm in the era before scanners. But we got our impression with difficulty, but delivered that appliance. He did fine. He did fine from then on. And particularly these little kids are so adaptable that they just don't fail. They just get it once you put it in. Some have more difficulty than others, but you can get them through it.
if you if I always thought the 3 to 6 year olds were going to be the more challenging, but it's not. It's the older age group, honestly, because the younger kids aren't around their peers that are entering, pre-pubescent time period that are being affected by um, society and on social media. So they are very honestly easy to treat in general. And the thing that really matters is the parent in the selection of the case. Having a parent that is disciplined, and hopefully both parents are on the same page, it makes it easier. But once you get them fitting, that really the 3 to 6 year olds are pretty adaptable, like Dr. O'Rourke said, and easy.
So I have a couple other questions. One was if you could just speak to some of the other methods. I know one was mentioned in here about Vivos. Just your take on that or comparison with that. Yeah, how would you answer that?
Are you talking Vivos like adult or like Vivos like
Very
Head
general,
Start or
yeah, Geno of therapy. And so I don't want to avoid those because, right, they're all in the same world of airway, right? And so there are different methods and therapies, but just what you guys are doing in orthotropics. And obviously, I know you're aware of it. We've discussed it privately. So
yeah.
I guess that's,
Well,
yeah.
I think that so the main difference is one, I think the amount of time that you're in the appliances. So, those appliances are functional, they're working when they're in, but the child also goes without the appliances, right? So the behavior there may not have is they're not consciously being reminded to change the behavior. Whereas with the BioBlock therapy, they're in 24 hours a day, except for brushing them in every single phase. And so, yes, the child has to learn consciously, they first have to learn, but it's there all the time. So they have the reminders there for their posture where they're supposed to be. Eventually, that's supposed to be coming up the ladder of unconsciousness, so they don't have to think about it. Um, I do feel like the other big advantage is that AP growth that you get. I haven't discovered what other treatment can provide the mandibular growth forward, and the maxilla growth forward like orthotropics does. Um, and as far as a Vivos in adults, to be honest, like I have some vague knowledge of it. I don't provide it at all, but how I guess how is an adult jaw growing like a child's jaw at that point? We don't have the same abilities to attain an outcome that's going to provide that much forward growth as an adult. So I do need to learn more about that. I've kind of called Vivos a couple times, wanting to put my toe in there and learn about it. But honestly, I've kind of stuck with this specific treatment on purpose because I would like to master this technique specifically. And I know there's a lot of other providers out there, that have a tool bag of different armamentarium to provide. And I think that's great. I just have not chosen to do that. Um, but orthotropics isn't for everybody. I will also say that you have to have the right family too. And so, there's times where I've had to provide a referral for a child because I did not think it was the right case or the right family for the treatment. So it's great that there's other options out there if orthotropics is not um, a good case selection for that child.
Thank you for that. I always think that's a difficult question, right? Any of us as speakers or presenters, and somebody's talking about fix, and I think you just answered that question. Like, what is a good fit? And seeing this at just such a young age change the trajectory to me is just heartwarming of what is possible with this natural growth, what orthotropics is really, I'm going to say, based on. I mean, you're getting to see that change doing this with this type of technique. My big question, we only have 3 minutes, and we're going to do two things here before everybody logs off. But one, I'm going to put Dr. Maria Miller-Rinaldi back in the hot seat. She doesn't know these questions were coming.
I
But
don't.
she doesn't. What she's hiding from you is that she's taken all this knowledge and then embedded saliva hacking into it. And I just briefly, she is going to be one of our certified clinicians who've been clearing cases. I say clearing of the red complex. You've been doing a fabulous job. What nobody knows, she's sensing these amazing cases. But can you we talk all the time about how the oral microbiome shifts because of airway. So just maybe a little 30-second clip here, and then I'm gonna share some slides, but just the work that you're doing on that side, because you're changing their trajectory. Not only we're seeing behavior health, right? We're talking oral systemic health, but I'm going to talk even just from chirogenic, I mean, not getting cavities, not getting periodontal disease. So give us a little take, because you did not really speak to that. And I know it's on orthotropics, but that's changing the future as well.
So, I was thinking about this, Laura. We have salivary tested some kids. And I would actually like to see it go more that way because one thing that you do see with these appliances and they're wearing them all the time is, their hygiene can sometimes suffer, and there is inflammation that develops. I have seen a kid get a, oral fungal infection. So, you have to, the great thing about the BioBlock therapy is that they are removable appliances, right? So it does make it easy, the hygiene should be easier than fixed appliances, but they are wearing them all the time. So, it can be a little bit more challenging. And I think the salivary testing, I would like to see to get parents to actually start salivary testing before we, implement treatment and then maybe test them halfway through to see how it's changed because we haven't necessarily resolved their mouth breathing at that point. Most of them we haven't. It's coming in the later phase of treatment. So and their dietary intake, there's obviously a lot of influencing factors that are going to affect the oral microbiome. But I do think that we hit that pretty hard with the adults and our patients, and we're still learning. But I think I would like to see that transcend to the children because wouldn't it be great if we're recognizing those red complex in a child and how we're going to change that long-term periodontal support system if we're getting rid of that earlier? Because who knows, by the time we test them as adult in their 20s and have red complex, where did that start? You know? So I would love to do that, and I would love your help with that. Maybe trying to help implement that, and I don't know, maybe do a study on that or something. But obviously, the earlier we hit it, just like orthotropics, if we can hit affecting their oral microbiome, how is that going to change their trajectory too?
Well, I couldn't thank you enough. You're leading into something that I don't even think you are aware of. I'm gonna just share. You can see my
Okay.
here. I was published with Dr. Rochelle Beatty, myself, Dr. Vigorous, Cami Haas on the technique, our method of test, treat, repopulate. It is out in Frontiers. Please go look at that. And what I want to share with everyone is that that is exactly the technique that we're teaching in our workshop on June 26th. 27. And you've gone through a lot of this. And so that's why Dr. Maria Miller-Rinaldi, I call her Dr. Maria, so it's hard for me to say all her long name there. But Dr. Maria, I just thank you so much, and Dr. Work. But really, people are interested in putting all of this work together. We want to connect this sleep, the saliva, and now we're connecting metabolic health with sugar solutions. And at this workshop, we're going to be handing the information to you. I actually have the printouts all ready to go. You're giving your treatment guides. You're not to be, I got to worry about creating it. We're going to hand them to you with sleep, with saliva, and even the Glucose Goddess book. You're going to be wearing your own Stelo. You're going to be doing your own saliva test. You're going to be doing your own pulse ox. So we want to invite you, those of you who haven't gone through the program or experienced it yourself, as she has, to come and do that, because it's just like you said, once you kind of come down the rabbit hole, Dr. Maria, it starts taking you off on all these different directions. That's how then she found, right? Dr. O'Rourke, it's like, wait, I want to be practicing this way. And I say, whether we're working on children, working on adults, the first level is just really getting the knowledge, understanding it so we can put it together. And Dr. Whit Wilkerson, I want to share this with so many of you out there and make it as simple and as easy as possible. In fact, we're going to be certifying clinicians. So I invite all of you to join us here in St. Petersburg. I'd love for you guys to take advantage. There is here, as an IDMSS partner, you do receive 10% off with that code. So that's S310. Please go put that. That's our S3. So that's what we love to come and have everyone experience that. So doctors, I just want to thank you so much. Just really heartfelt. Love the work you're doing. And if you're interested, please reach out to them. Follow them with Orthotropics. I think, again, this therapy is changing lives on so many levels. We could talk about GI, we could talk about sleep, we could talk about mental health, we could talk about adulthood. It doesn't end. We could talk about the blood markers, and love to be doing more studies that we can show you the proven results. That's what we're trying to do here at IDM, is really bring these results to you, showing you what's going on in everyday practices, not just talking
Great
about,
job.
yeah, and not just being theoretic, but here, people practicing this way and being able to truly integrate oral systemic care into their everyday patients.
All right.
Thank
Well,
you
thank you so
so
much
much
for
for
having
having
us,
us, Laura.
Laura.
Thank
And
you.
Laura, some people were asking for my contact information,
You
so
draw-
I can send it to you, and you're welcome to
Okay.
pass it on to those.
Perfect. We do a
Okay?
follow-up email. We'll do a follow-up email with it. So those of you who want to continue can do that, and appreciate you. And thank you again to Cell Life. Good night, everyone.
Good
Thank you.
night.
Thank you. Thank you.